the clinical program manager with Children's Hope Alliance. In our region out west, specifically with Macon and Jackson counties, we have primarily adult substance abuse programs, either on an educational level, basic outpatient, or intensive outpatient. We do see some adolescents from time to time that come from our high school that we serve, as well as the court system. Okay, so just starting off, just general information about the ASAM. It is the acronym for the American Society of Addiction Medicine. The manual can serve as an assessment and placement tool for professionals to use when they're trying to look at need and a proper dosage to help treat that need. It is part of medical necessity now when we're dealing with MCOs and having to justify medical necessity for services, especially if it's a substance abuse specific service. They want to look and see, how did we get the level that we obtained to level them out for care. So having some kind of a worksheet or grid has satisfied our MCO. We're with Smoky Mountain Center out here, and so that is part of what we continue to do in a lot of our adult programs, and it's been, we've been successful with that. The ASAM manual is not a replacement for a comprehensive clinical assessment or a multidimensional assessment, and it is not a replacement for the DSM-5. So you're not able to get a diagnosis off of an ASAM worksheet. We look at the 6 dimensions. We'll start with acute intoxication and withdrawal. I think intoxication pretty much speaks for itself. That's looking at the person who's presenting in front of you. Are they under the influence? How severely intoxicated are they presenting? And if not, then looking at the risk of withdrawal or the presence of withdrawal. Sometimes folks will tell you they're withdrawing. They know it. They feel it. Other times they're not, but you are able to get enough information off of the assessment when they're talking about their duration of use, the frequency of use, the intensity of use, their date of last use, can give you an idea of where their risk level is for withdrawal. Forgot to mention earlier, but as we go through each of these dimensions and define them, right behind it, I've crosswalked it to questions on the assessment as to where we can find some of that information. It is important to know enough about the drugs that are out there, detox protocol that's been established for them, and withdrawal symptoms that folks experience. There are certain substances that, depending on chronicity and date of last use, could be very dangerous or lethal for someone if they tried to withdraw on their own. So when in doubt, a medical professional, we have a medical director here, someone that could speak to that could give you some help identifying, is this someone that needs to redirect and go somewhere where they can safely be monitored by a doctor and detox first, or their risk might be lower for that. With withdrawal, oftentimes consumers we serve and just individuals in general think of all the physical symptoms associated with withdrawal, and oftentimes the mood shifts don't register for people that could potentially be a withdrawal symptom they're experiencing. So spikes in anxiety or spikes in depression, irritability, aggravation, frustration, things like that can come up. Sleep problems, appetite changes, and then there's a whole list of all the physical things that someone could experience if they are going through withdrawal from a substance. So when we're looking at Dimension 1, and we crosswalk that to what we now call the admission assessment, I tried to go through our old comprehensive clinical assessment just to look at all the areas I could think of that people have reported things or talked to me about things, and where that can be built into here. But certainly I think any area on that assessment, depending on how well they present and if they're a great historian, they might give you everything you need right off the bat. So how are they presenting at the assessment, and what information are they presenting to you as to why they're there? Reason for assessment, if you have youth that are court involved, and so someone from the court system is referring them to you, or a hospital's referring them to you, you're going to get information from your referral source to give you an idea of why they're asking for an assessment. There's a substance abuse question right around the substance abuse section that asks, does this person have a substance use disorder? Sometimes you don't know. That's not why they're referred and you don't know, but you can always go back later after you finish your assessment and start asking those questions. If you feel they have one, you can always go back and answer yes there. Same for current diagnosis. They may not be coming to you with an SA diagnosis. It may never have been discussed or assessed. You may be the first person that's bringing things to the surface. So again, you might not know how to answer that yet, but getting through an assessment, you could probably figure out at the end if you're diagnosing for that, you could go back and you could hit yes on your assessment. Sometimes folks have a treatment history. Not all the time do we get all of the records. I know in our adult world, sometimes we know they're coming out of a hospital, but we may not get the hospital discharge paperwork until days after they've landed in. So sometimes we're operating on bare minimum when we're assessing someone. We're really relying on them to tell us the things we need to know. But if you have all these documents, somewhere in that you should be able to see with a discharge summary or some kind of an assessment summary coming from a hospital or court system, something that indicates whether or not substance use or treatment has been involved for that person. The medical history, there's a lot of questions. They kind of break all the medical issues down on the admission assessment. So, for instance, they ask about hospitalizations. And I know I'm thinking medical hospitalizations, but in an adult world, they're thinking inpatient. So that's a place they're going to tell me if they've had inpatient treatment before. Sometimes with questions about ongoing illnesses, what I'm looking for is to see if there's anything that's chronic or acute. If we look at Dimension 2, this is strictly around the medical. So are they reporting current medical issues, chronic issues? Again, your medical history on the admission assessment is going to give you an idea of what's existing or what they've had in the past. What you're picking up on, again, is that relationship of the medical to the substance use. And as you're looking at how to ASAM that, you're trying to picture this person's medical condition. How severe is it? Would it inhibit their ability to do well in treatment? Are there things that are going to surface because of the condition that's going to make it difficult for them to engage in treatment? Or is it going to make it difficult for them to be abstinent from substances? Chronic pain is one that keeps coming up for me. We have a lot of folks in our adult world that have chronic pain issues, and they're there for opiate addiction. And so not being on opiates now and trying to manage with other things but still having chronic pain would tell me if they're still experiencing that, they could have triggers to want to use. Their relapse potential could be quite high, and the pain in general, depending on the treatment that we're prescribing and the structure and the setting, might be too intense if they have a lot of pain. We're in an intensive program, for instance, that meets 9 hours a week for three-hour sessions. And so if somebody had real severe pain, let's say back pain, where they have to keep standing up, sitting down, moving around, we would be able to support that in our group, but there might be other settings that would impact their ability to sit, or times a day they have to take medications or do certain therapies, could interfere with treatment schedules. So a lot of things to take into consideration if they do have some medical conditions that are present. Sometimes they do, and it's just not going to impact any kind of substance use treatment. It's going to play a very minimal role, if any role, in their treatment. So some of the areas on the comprehensive clinical assessment or the admission assessment that might help you answer the medical, the treatment history. So have they talked about previous types of treatment for their medical condition?
Or have they been reporting mental health and substance abuse treatment? Is there anything they're telling you in the outcomes that have to do with their medical condition? They had to quit a treatment early, or they had to suspend a mental health or substance abuse treatment because the medical condition was active to a degree that they could not finish what they had started. Your medical history questions are going to answer a lot of that as well. When you get to the admission assessment where you're looking at recovery environment and barriers to treatment, we can also take into consideration the medical they reported. And is this something that could be a potential barrier for them to get to treatment, stay in treatment, engage in treatment, etc.? And consequences from use section. When we're in the substance abuse section, there is a question that says, or kind of a category of consequences. And there can be a good place to identify if some of these medical conditions have developed because of chronic use of drugs or alcohol. Also, health issues that they might report. There's a question on there. Do you or someone else think that your medical issues have been the result of drug and alcohol use? Has a doctor ever told you to quit drinking or quit using? Sometimes if they say yes, I'll ask them to elaborate. And they may say, well, it's my primary care physician, and they're telling me that this is starting to show up, fatty tissue on my, liver, or I'm starting to have problems with my pancreas, and they feel like it could be related to my alcohol use, and so they've just suggested that I quit. That's good information to have. Medication. Do they report medications that are specific to treating medical conditions that might also be medications that can be abused? The medications they take, could that impair their ability cognitively to be a part of treatment? So sometimes folks do take controlled substances as prescribed. They're not abusing them. We do have adults in our addiction program that may be prescribed benzodiazepines for anxiety. And so, we tell folks, if you present for treatment and you don't appear impaired or you don't act impaired, then you can engage in group. But if you're appearing impaired or you're acting impaired, even if it's with what you're prescribed, then we're going to have to make sure you have a safe ride home, but we can't have you in group that way. So really being mindful if they are reporting medications like that, asking them if they have a set schedule that they're taking them, to try to get an idea of what the treatment schedule is going to be for them, and seeing if they can negotiate things with their doctor so that they can engage in treatment and be coherent and kind of pause on the medication until they get back home where they're safe. Dimension 3 is all about the emotional stuff. And so this is any current psychiatric, cognitive, emotional, behavioral challenges that are happening with this person. How would that impact their treatment? Okay. We screen in our adult program, we're screening because we're doing a comprehensive assessment, so we're looking at mental health and we're also looking at substance use. And on rare occasion, but it does happen, if someone is presenting to us and there's some real severe or persistent mental health symptoms occurring that we feel is going to impact them sitting in a group and functioning in a group, then we will refer them to a provider, whether it be med management or counseling or a combo, to get that stabilized before we will admit them into our treatment program. Now, a lot of folks in our treatment program are going to have co-occurring disorders, whether it's trauma, depression, or anxiety, things like that. But these are folks that are managing. It's not, the emotional health is not flaring up in a group or distracting to others that are in that group setting. Are there chronic conditions that can impact their treatment? So any emotional health is a long-term, chronic. Looking at treatment history and what they're reporting, how severe is it? Were conditions pre-existing before routine use, or have they happened afterwards? That's an important thing to ask. Oftentimes if folks kind of give me their diagnosis, I'm diagnosed with this, and that, I like to kind of, ask a lot of questions about that to see, because sometimes they're giving you a whole list of diagnoses that they really don't have. Okay, when you iron it down, look at trauma, for instance. People wear all sorts of diagnoses throughout their life, and somewhere, if somebody is really doing an assessment and looking at trauma, they can call these 2 or 3 things PTSD, because that's what they are. But if folks are reporting I have severe anxiety or severe depression, or I have been diagnosed with a bipolar disorder, I like to know what was happening before they started using substances routinely. And sometimes folks are very clear. They can remember childhood or remember that age before first use. Well, how did you do in school? Were you comfortable in school? Did you do well in school? How did you do at home? And so if they can really make a clear distinction that this stuff never really happened until I was in, this grade, and you're making a connection, it was around that grade that they started using routinely, then you may be looking at mental health conditions that have developed because of the use. And diagnostically you can do it a few ways. You can either address that in a summary and say, it's very, based on what they're telling me, these are the things before and these are the things after, and I'm just keeping my diagnosis this way. Or you can do rule outs or make notes, need to assess further, after they have been in treatment for a while for their addiction. You can always assess that down the road. It really doesn't matter if it's existing now with the substance use. It really doesn't matter in terms of treatment. When it happened, it would need to be treated together. We're in a world where, whether it's substance use and mood disorders or substance use and trauma, we're in a treatment world where nowadays it's expected that we're treating both together. And how are we going to answer for our treatment? We're going to actually get into some of that type of thing. Crystal and I went through an ASAM the other day, and so we were thinking, okay, over here, and then we were thinking over there, but at the end, everything lined up. It lined up, I think, exactly the way it should, where you can support both, but sometimes there's a heavy end of support one way, but you can still support on the other end. It doesn't matter which is primary or which is more severe. There's ways to support both. Also finding out what their coping mechanisms have been for mental health, because that's a place to find out about self-injurious behaviors, and substance use included. And how have they coped with mental health in the past, or stress, or other things that have gone on. That will help you gauge if they do mention that drinking or using helps them take the edge off, helps them be less anxious around people or in school, helps them numb out. They're already telling you there's a heavy relationship there between drugs and alcohol and their mental health. And so that's going to impact the way you are rating them on their ASAM. So again, a lot of the same sections come up on the admission assessment where we can get information. With the emotional, behavioral, and cognitive, you can get that again throughout the whole entire assessment. So the reason they're there, what kind of treatment history have they had? Paying attention to hospitalizations and high-end treatment, because that's going to tell you about, at least historically, the severity of the emotional health. Family history. Usually on that question, when I'm doing an assessment, I'm not just stopping with the question about is there mental health or substance abuse in the family history, but I'm also asking, what is it like to grow up in your family? So I can get an idea what stressors that person might have experienced, or what they were around pretty regularly? Is there chronic stuff that seems to happen? Sometimes if they say, well, my mom had this and my grandmother had this and my aunt had that, I like to know, was it on the same side? Is that all on your mom's side? Is it father? Is it both? Because that can tell you how persistent or prominent mental health is in the history, which might answer a little bit about what that child or adult is going through. Trauma history, people approach this differently on the assessment. When I get to trauma history on the assessment, I'm already thinking this is the one area that I can ask a lot of questions to give me an idea if I'm looking at a PTSD disorder or not. And so how we ask that question, have you ever experienced trauma? A lot of adults don't even know how to answer that. What do you mean by trauma? So I try not to lead them in one specific way, but I throw all sorts of things out. And some of those things I know I really want to know. So I may say, well, some folks think of trauma as emotional abuse, physical abuse, sexual abuse. They might think of domestic violence or witnessing domestic violence, but other people think of combat or think of a car accident or a significant loss of a loved one. And I try to start thinking of all the things that I've encountered that have been built into a PTSD diagnosis in the past, but throw it all out there. And then I let them kind of talk and say, what, is there anything you've experienced? When they say yes, I start thinking, here's my questions. Tell me a little bit about how it's impacted you. If they're not really, some people will answer. It gives me everything I need to know about PTSD. Sometimes they aren't lining it up or they don't know how to articulate it. So I start asking those questions, and that I'm thinking about the criteria, the repetition or reoccurring, the active avoidance, all of that. And that's the place I capture it, because on our admission assessment, if you continue forward, if they're not there because of that, if they're not referred because of that, and that's the only place we're really targeting that, we could get through the rest of the assessment and possibly overlook a PTSD diagnosis. So I tend to use the fields on the assessment and ask more questions and build things up to get a good perspective. Educational history. We're talking about emotional still. I'm thinking, okay, yeah, I want to know how they did in school, and I want to know if they had any learning difficulties, or do they ever remember getting tested for anything, or doing a lot of one-on-one with teachers, trying to think of those IEP related things or accommodations to see if they had any of that. But I also want to know if they didn't do well in school, was there emotional things going on back then? Was there bullying going on? Some might say, well, how did it feel to be at school with other kids? How did you interact with others? What did it feel like to be in your shoes on a typical day in school? And that can also help answer some of the emotional history that we might be trying to capture. Vocational history for young kids, it's going to be blank. But I think in our state, after 16, they may have some work history. In an adult world, especially if they're going through vocational related services, it's really helpful to know how many jobs have you had, kind of that breakdown like on an application. How long did you stay at those? What types of work did you like? Did you not like? And what were some of the reasons that you ended employment? Because you want to see if emotional stuff impacted that. So these are all the areas to see how much does the emotional, behavioral, psychiatric conditions impact all these areas of life. What kind of medications are they taking? Their financial situation. This also gives you ideas about triggers that are in their environment that might flare up the emotional conditions. Barriers to treatment. I've asked this question and with adults. I've said, tell me the things that are in your life or your environment that you know are going to totally support your recovery effort. People, places, and things that are going to support you in this effort. And that tells me their strengths. And I'll even say internally about you. What do you know about you that you know you're just totally going to rock this out. And then I ask the other thing, what are the things that are going to get in your way or have a potential to get in your way? People, places, things about you that you're aware of. And that helps. If it's real severe or persistent mental health going on, sometimes that's what people identify. When I don't take my medications, that's going to get in the way of my treatment. When I'm not sleeping right, that's going to get in the way of my treatment. Seasons of the year where their symptoms may flare up, anniversary dates that might trigger an emotional response, might be part of those barriers that they are highlighting. And so we look at comorbidity, and that question, where it's at in the admission assessment, is before you really know. Unless you really know them walking in or know where you're going, you're probably, if you don't know at that point about diagnosis, you're not going to know how to answer that until you get to the end. And then that's another item you can go back and answer. But that's your impressions too after the assessment. Are there truly like a substance use disorder and a mental health disorder that's co-occurring? Are there developmental disorders that have been documented? Because not all of us, we're not getting into a lot of the diagnosis of developmental disabilities, but we might have a lot of psychological evals and other things that tell us, about that. And if we see a co-occurrence with mental health and substance use, what kind of relationship are they talking about during this assessment? Does one trigger the other to flare up? Does one help the other to calm down? That's going to give you an idea, if this isn't treated, this isn't going to work. If that's not treated, this isn't going to work. And so really thinking about a treatment protocol. If we take drugs away, we may be taking the main coping skill away for somebody. So if we do that, we need to be prepared for all the things we can put into place and things we can suggest that person to do. So readiness to change and motivation. This is kind of another area where you may have to make some assumptions, but you're going to get good information to be able to gauge how motivated somebody is or how ready they are. Now we're looking at substance use. And so motivation is different for different people. What we know is most adolescents that are required or ordered into treatment don't want to be there, period. So their stage of change may not be ready to address or work on things. That's why we do have some practices that support adolescents, but it's kind of a backdoor approach to substance use. They get to talk about other things that they're more willing to talk about. In our adult world, whether they're DSS involved or probation involved, sometimes they present and they know there's a problem, and they'll tell us, I just need you to know that even though they're telling me I need to be here, I want to be here. It's really important for, there's a lot of adults, it's really important for them that you know that they're voluntary, irregardless of anybody else telling them to be there. Sometimes they'll tell us, I don't want to be here. I think this is a crock. I don't think it's going to help. I don't have a problem. So you have to kind of figure out the constructs. Some programs may require that somebody's in a certain stage of change. Our program doesn't have that requirement. In our adult world, we have other requirements, but our program's built to try to help somebody move through that stage of change too. And so that tells you a lot about, when we enter treatment, where are they going to be? And isn't it great to learn ways to dance with someone versus wrestling with them? And so are you going to have that time to do that? What is some of the prep work that might be needed to get them ready for whatever treatment you're thinking about recommending for them? And they'll tell you enough to where you can make an assumption about where they're at with that. So questions on the assessment that help give us an idea. How ready are they to change? Why are they there? Is somebody requiring them to be there? And how are they presenting when they are sitting in the seat across from us? I this is just me. I will not move forward. There's several times I'll suspend an assessment and just not even do it. If someone sits down and says, I don't want to be here, I don't want to talk about anything. Okay. Anything? Your birthday? Anything. I want to know, will they talk about their birthday? Will they talk about their favorite holiday, or are they that locked down? Nothing. And if I can't identify anything they want to talk about, I'll kind of move to plan B. You want to play a game? Want to play some cards? Want to take a walk? Anything to engage them to see what I can get. But if they're nope, I say, that's fine. We don't have to do that right now. Because that's where I'm done, and I'm not going to try to push or press. Sometimes they're ready to talk about one thing, and they're not ready to talk about something else. So they may be willing to tell me all day long about their depression and anxiety, but they're not going to tell me anything about their substance use, because they know everything they tell me is going to go back to DSS, or everything they tell me is going to go back to probation, and so they're not going to hang themselves out to dry there. But they'll tell me about depression and anxiety, and that's all they're going to tell me. I kind of just work with what I get, and play it by ear and how far I'm going to go in that assessment. And at the end, it's okay if there's items I just cannot, complete. I'm going to be gauging their stress level, and, if I have to pause or whatever, it's just, this is what I've got, this is what's incomplete, and this is what I recommend, and if anything, we're recommending for a further assessment. Their treatment history can tell you a little bit, at least historically, where their motivators were, because we're asking them what was the outcome of treatment. So sometimes they say, well, I was prescribed this, but I just didn't take it, So sometimes folks just don't like to take medication. And a lot of mental health relapses can happen because people quit taking their meds, or they want to cut down, or they want to, take some and not the others. So the outcome, are they indicating anything to me that if they have not had positive outcomes in treatment, is it because they disengaged, or because they didn't like, the treatment, or they didn't like the counselor, or they just weren't ready? Adults articulate things differently than kids. So with kids, you guys are experts in figuring out how you get some of this answered. Adults will be a bit different. Family history, when I'm asking them, what's it like to be in your family? I'm trying to pay attention. Does the family use together? In that home, are they around drugs and alcohol all the time? So if I'm telling them this is an abstinence-based program, or, this is a program where we're looking at harm reduction and, stuff, realistically, are they going back home after our session and it's all there, and there's people in their environment that are encouraging them to use? That will help me understand where their motivation is at and where their readiness to change is at. And then their social history, again, who are the relationships in their life? Is this a little bit like the family history? Have their relationships been built on drugs and alcohol? Are their current friendships drug and alcohol based? And what's their attitude? If I start having that conversation about an addiction level treatment and the people, places, and things, what's their attitude? Sometimes folks say, I can quit. I can be around people that are using. I can be around it, but it doesn't mean I have to use it, and it doesn't mean that I have to. But if they're there for an addiction level treatment, or that's what I'm screening, I already know, that's going to impact where their motivation is. Their motivation could change one day after the next. With trauma history, any indications of how they view trauma and their essay, any relationships. For the folks that are willing to talk about trauma and they're willing to talk about substance use, they'll give you, more times than not, they're going to give you that relationship. They may say something, I know things that some of our adults have told us, marijuana or alcohol it helps, I get real triggered and I get real elevated. I can do that. It just helps keep me calm. It helps, So a lot of these negative coping skills people develop, it's serving a benefit, it's serving a purpose, it's helping to try to minimize some of the things that are coming up with trauma. And so that's a good place too, when you're looking at readiness to change motivation, they're talking about that relationship, you're already thinking too, what would override the other? These two need to be treated, but what am I looking at here? Sometimes we get to the end of an assessment and there's a real high need for treatment for PTSD. And there's a real high need for treatment that's substance use. So who makes the call, what they're going to get and where they're going to go? We'll talk a little bit about that as when we work through some of the worksheets and stuff. But it also tells you if they have not developed healthy coping for trauma or other mental health, and substance use has been their primary coping, and you're about to engage them in treatment for SA, it tells you a little bit about how much they're going to struggle when you take the coping mechanism away or you ask them to get rid of it. Legal history can tell you a lot about motivation. We have some folks that just cannot pass a drug screen with probation. Probation calls sometimes and says, I'm about done, I'm sending them to you. They just tested for the 4th time in a month, positive, and this is it, no more, they better come to treatment. And it's kind of like, you fix them. We're sending them on and you fix them. Don't let them come back and test positive again. We don't want to see another positive. But that tells me, okay, when you have to go sit in front of a probation officer and you're having to do a drug screen and you have jail hanging over your head and you're still testing positive, then there's some choices being made that tells me just how connected you are to your substance use if you continue to make these choices. Or sometimes, unfortunately, DSS involved. Repeated involvement with DSS or repeated drug screens coming up negative, and it gives us an idea, okay, there's choices being made even with DSS working a plan that this child may not return back home and the substance use keeps happening. It tells you how severe and persistent it may be in someone's life and where their motivation would be. Because isn't it easy to think that if we had a probation officer, there'd be enough motivation for us to do right and get done, so we don't have to keep paying for it, we don't have to keep going and getting in trouble? Or, if I know that the only way I'm going to be able to keep my child is to stay clean, that's a high motivator for me, so I'm going to stay clean so I can keep my child. So when we're looking at things like that should be motivators, but they don't seem to be motivators for people, tells us how progressive that illness has probably become for them. Medical history, again, is there any insight into their attitudes or their beliefs concerning their medical conditions? Do they have medical conditions that have been caused or where drug use or alcohol use has contributed to those conditions, but they minimize that? Well, there's other ways you can catch Hep C. I don't really buy that I caught it from this. Or there's other people that have liver things or pancreatic things or all these other things, and it doesn't necessarily have to come from this, so I don't think, I don't buy that. That can tell you, okay, especially if they're continuing to use. If they have conditions that's it's been instructed, do not do this. If you drink, if you use, if you this is what can happen. And they continue to do that anyway. That can tell you a little bit about, that's not going to be a motivator for them. Their medical is not going to be a motivator. And so if they're continuing to use, that can tell you a little bit about how motivated they would be to enter treatment and try to tackle the substance use. Their preferences, I don't ask somebody, what's your preferences? Because a lot of people don't know what I'm talking about. Like, what do you mean? Like, they'll sit in a group room and say, like, coffee or tea or, what do you mean? So I usually just say, what's important to you? If you think globally, your values, your interests, your beliefs, people, things that are important to you, all the things that you just very hold near and dear to your heart, And then they start to tell me a lot, and I can learn about their attitude. I can learn about their culture. I can learn about the way they think when they start spouting off all the things that are important to them. If they tell me, my kids are ultimately the most important thing in my life, and I am here to do whatever I can do to keep them, tells me that they might be more motivated for treatment, or the number one thing on my plate right now is saving my marriage and I'm ready to do whatever. I don't have a conversation about, oh, change has got to be for you. It can't be for anybody else. Whatever is getting them in the door, whatever's motivating them, I work with that. Just work with it, because over time motivation can change, and we've had some folks make it through our program and say, even if my marriage deteriorated right now, I would still stay clean, because this is a lot better than where I was. So you can see that change sometimes. I will put this in as I'm thinking about it with motivation. Old research suggested that people who were required into treatment did not do as well as people who enter treatment voluntarily. That's not true. Research now shows that folks can have the same outcome. Both parties can be successful. We've seen a lot of people coming in treatment. They absolutely, I'm gonna be okay. I'm not gonna gripe and moan and group. Okay, I just need to let you know that I'm gonna stay clean because that's your treatment requirement. But when I get out of here, I'm probably gonna go back to using. Okay. But I'm glad you can stay clean, because that's the rule of treatment. So I'm glad you can show up and do that. And a lot of people might be adamant at the beginning, but their motivation changes over time, and they're buying into it a little bit. Like someone that might graduate and say, thank you for pointing out that alcohol's a drug too, because I knew the other one was a drug, which is why I came, and I did not want to quit drinking, and everybody kept telling me, you're going to have to quit drinking if you are in this program, and I didn't buy into that, but I finally did, and now I know it's a problem too. So even attitudes change about, drug of choice versus all drugs, total abstinence versus, I can use this over here, not over there. Depending on the program you run, you'll know it'll dictate, is it total abstinence, is it harm reduction? That's going to dictate how you engage with that consumer. And no matter what kind of program, you can always find ways to engage with where they're at, kind of meet them where they're at. Even if they're not highly motivated, it can work. Substance abuse section gives you a lot of history of how severe things have been. Did someone report that they quit or they've stayed clean? If they did, how long were they able to stay clean? Well, what helped them stay clean? What did they do back then? Would those things be helpful today if they're trying to get clean again? So you can tell a lot about someone's motivation just in their walk through treatment in the past and achievements that they've made. So relapse, getting into another dimension here. Relapse, continued use, or continued problems. Ultimate question here is, right now, how at risk is this person of going right back and using? How close are they to a relapse? Are they in immediate danger of severe substance use or mental health distress? So continued problems can be part of that, and how imminent those are. What coping skills have they reported that they've used before when they were dealing with their substance use disorder or their mental health disorder? If the consumer does not engage in treatment currently, how probable and severe are the problems and distress if they don't get treatment right now? So basically, what's their danger zone right now for relapse or having continued problems? How severe would those problems be without treatment? So again, we want to know about relapse history. We want to know about problems, mental health, substance use, stress, whatever. Their probability to continue using, if they talked about coping, if they talked about life stressors going on, all sorts of areas on the assessment that are going to be able to answer those questions. Recovery environment. So that is a question on our assessment that asks what kind of environment surround them to help support their recovery. So who's in their life? What kind of influence do the people that are in their lives have? on their attitudes about drug, alcohol, wellness, recovery. What types of situations have impacted them or have potential impact on the recovery efforts? So, do they have financial issues that cause a lot of stress? Or, opposite, have they found financial stability through accessing substances and becoming an entrepreneur of? Their residential situation, educational situation, vocational, legal, like all that stuff. Basic needs. I was in a meeting at the detention center a few days back. We were talking about the same thing. Basic needs. Food, clothing, water, shelter. These are real core basic needs for somebody to be able to start recovery. And those are those primary things that folks are going to have met. So those are very prominent things. If somebody is homeless with no money and no job and nothing, they're going to get those needs met immediately. Unfortunately, at least in our adult world that I'm more familiar with, these needs are met through friends that are still using. Or I think I've recently learned a term, trap house. I had never heard of that term, but someone informed me that a trap house is that landing spot that people know they can come and use, they can crash, they can recuperate. So, trap house. So where are these people going? Because that's going to tell you, how's that going to impact them coming to treatment and doing well in treatment? And it's also going to give us an idea, okay, what are all these needs? Because as we know, it doesn't matter how basic of an outpatient service it is, usually a therapist or a Q or someone plays a case management role. Even though we can't bill case management anymore, we all start to play a case management role because we know how important all these things are going to be for this person's success in treatment. Child care comes up for a lot of folks. They want to access treatment, but they need to work out child care. So what are all the resources that we can connect them to? Transportation resources, etc. And all the items on the admission assessment that we might be able to gauge what's in their current environment. Again, any family that's in their environment that can either be helpful or be harmful. Their social status and their current set of peers, helpful or harmful. Trauma history, how are they coping? Even if they don't have PTSD, how do they cope? Forgot to mention that, but if somebody denies all the PTSD stuff, when I'm asking them about trauma, I ask them, it sounds like you've coped well. How did you cope? And that can tell you a lot about resiliency, and they might have a great toolbox of skills. The cultural influences, what is acceptable in a family system? Had someone tell me one time, pot, when their family goes outside and smokes pot, it's like smoking a cigarette. I mean, it's just everybody in the family does it. They grow it. It's their culture. They were raised on it. To them, it is not bad. It is totally acceptable. Our program is total abstinence-based. Our intensive program is. So we have to work around that. So I say just 12 weeks. If you want to change your mind after 12 weeks, we can't do anything about it, but for 12 weeks, got to have you as a captive audience and be completely abstinent. But that culture is part of their mindset. I mean, that's their fiber. That is their beliefs, that's their attitudes, that's their motivation, that's everything. And that's going to tell you a lot about, what's a potential barrier, what's a strength for their recovery. And vocational, even educational history. How are they functioning in school? Where do they find comfort in school? Do they find comfort with groups of folks that use? If that's where they find comfort, that's where they feel better emotionally. Their vocational history, there are just, drugs, alcohol is everywhere. There are certain vocations where they're very prominent. So this person has to work, this person has to pay bills, and this person's trying to stay clean, but they're in a work culture that that absolutely endorses or encourages, stimulants or other things to kind of get through. They may work in environments where alcohol is definitely a part of their job, not just serving or being around it. But had someone tell me one time they worked for a beverage and spirits distributor, and their agency rewarded them for not developing problems with alcohol use. And so it was an incentive-based program. And so I don't know what kind of prevention work they would do with their employees, but they truly didn't want their employees to develop problems. But it was totally part of the workday to entertain clients and take them out. Consuming beverages, they're pushing a product, so consuming beverages and having dinner over beverages. And if they're seeing their clients as much as we see clients, think about how many opportunities they would have to drink. So, this person developed a problem because the frequency was just that. And so they traveled a lot. They weren't in their own home environment. And so dealing with sleep, just dealing with travel things in general, might not sleep as well as we are at home, might be in different environments than we are at home. And so this person had developed an alcohol problem because it was very ingrained in their work day and part of their productivity and part of their paycheck and everything else. So work environment definitely can be an impact depending on someone's substance use. All right, so those are the 6 dimensions. Now we're looking at levels of care. All right, so 0.05, that's your early education, prevention, okay? If we're working prevention, it's before problems are occurring. If problems have already started to occur, now we're working on a recovery plan. So level of care, this is consistent with folks that typically do not register to have any kind of substance use disorder at all. They may be in need of a harm reduction course. In our area, I don't know if this is statewide, but what I'm seeing out of the courts a lot now, we'll have folks come in because we're a DUI provider out here. So they'll say, my attorney or, I've been ordered by the judge to do a drug and alcohol assessment and take a class. So what we're finding is this class now is really a 16-hour prevention course we do, and now it's starting to become part of court orders. We work with a high school system and in one county, and the medical director informed us, I don't care what they register, if they don't register anything at all, before they can play sports, they have to do your course. Period, whether you think they need it or not. So some people are already required to do that, but other people, they're not required, but it would be really helpful. Now, everybody that lives and breathes on the face of this earth can benefit from taking a prevention course. But as a clinician or a professional, we're not thinking that as a recommendation for everybody. We really want to think of it in our work when we're recommending that or we're leveling it out to be put on a clinical document. We're doing that for the folks that really need it. Okay. This is a service that can be done in groups or individually. It can be a standalone intervention for someone that does not have mental health treatment needs, or maybe they have some mental health and you can embed this in. So their mental health is no disorder with an SA, their mental health is a primary disorder, but people here have probably reported they've used something or might have experimented around. Nothing really became routine. They didn't develop a pattern with it. And so you see it as, okay, there's some play, something's happened, they got in trouble at school, they got in trouble with the courts. It's become a problem to a degree, but not enough for a treatment dose, but enough that we might want to embed some stuff in while we're treating the mental health piece, just to kind of help keep it from progressing. Crime for Life is just one example of an evidence-based practice that's out there for prevention and education. We use it out here heavily in our DWI world because it's a required practice that we have to put in place for some of our DUI folks. It's an expensive training, but it's one that I would encourage, anybody that could participate in, as a participant, just to learn about what it is. It's designed for people who have never had any risk factors at all and just want to learn, parents, youth groups, general community, all the way up the line through folks that have had DWI offenses. And so it's great. It's a decision-making course. It's not abstinent-based, but it's a decision-making course. And it is naturally designed to move somebody to a contemplative state of change, where they're thinking about changing something related to their use or, of alcohol or drugs. So this would not be where people with treatment needs would go. But somebody that's had a little in and out with it, that's it. They need a little dose of something. The end. Level 1, that's basic outpatient. So this lines up a lot like mental health. Level 1 mental health is an outpatient center. They may see somebody an hour a week or whatever, do a group. So these are folks that have could have possibly registered a mild use disorder or maybe a moderate use disorder. And basic outpatient, again, can be done in group or individual sessions. The consumer coming here may just have an SA disorder and no mental health, or they might have both. In basic outpatient, they can have just one disorder. It can be substance use, it can be the primary, and treatment can be funded for that. If the intervention is for an SA disorder alone, that can be provided by a certified or licensed SA professional, or a licensed mental health professional, or duly credentialed professional, if it's SA alone. Mental health, a licensed mental health professional can treat both. Okay, and obviously, depending on who the funding source is, what the exact service is, it may come with its own specific requirements too. If somebody's doing an intervention for co-occurring disorders for mental health and substance abuse, the practitioner that's billing that therapy and doing that therapy has to be at minimum a mental health licensed therapist. So if I only am a licensed clinical addiction specialist and have never pursued a credential in mental health, I can treat folks with SA stuff, but I cannot treat folks or diagnose folks that have mental health stuff involved. That would have to go to somebody that has a minimum of mental health license. So some common things that come up in basic outpatient that can also help with level 1 type substance use stuff: cognitive behavioral therapy, examining and challenging the thoughts and kind of what leads to the emotions and what leads to the responses to emotions if substance use is there. So that's a practice that can help. Dialectical behavioral therapy, helping folks examine emotion regulation, crisis management skills, their wise mind, being able to stay grounded and thinking rationally. There's another dimension I can't think right off the top of my head, but that can help folks that experience triggers or thoughts around using. Seeking safety is an evidence-based practice. It was developed by Lisa Nahivitz back in the 90s. They did some research in women's inpatient centers for substance abuse and found, I think it was 70 or 80% of the women were reporting trauma. And that kind of pushed forward into an evidence-based practice called Seeking Safety, which targets both, or it can target one or the other. And it is just the safety skills. It doesn't get into the mourning and the integration phases of trauma recovery. So with the safety skills, it's all about grounding and all about replacing self-injurious behaviors. And so if substance use is one of those behaviors, it can help folks that are learning how to manage things without using drugs or alcohol. Motivational interviewing, big, commonly used evidence-based practice in substance abuse. And someone said one time it's kind of like the Columbo approach. Like, why is that? I'm curious. Tell me this. Why this and why that? But it's kind of designed to get somebody to do their own struggle and their own wrestling, and you're just dancing and you're just curious. And you're just asking questions. But then sometimes you figure this is a place I can challenge. So I'll hit a challenge in. And then I'll back up and I'll be curious. And so when that person starts saying, well, I don't have a problem. Well, maybe I do have a problem. Well, yeah, everybody's telling me this, but I don't know. Well, maybe I do have a problem. That's kind of that work through to like, oh, okay. If you think you do, we can help with that. And you're like, yes, yes. They're there. They're contemplative now. I will say that as we get into the twos, there's a 2.5, there's a 3.1, there's all the, I am only focusing on just the increments that are the most commonly used things that are in our, within our catchment areas. I didn't include every single level on there. 2.1, that's your IOP. That's your intensive outpatient treatment. So that's usually where you see the moderate to severe use disorders that have presented. And I put on here the North Carolina Enhanced Service definition for IOP. It's the same for adolescents and adults. So you're talking about somebody who, if they need this level of care, you're talking about somebody that's going to be coming to a facility 9 hours a week for 3 3-hour groups, plus they need case management and individual counseling and transportation support, and you're going to be drug screening. Now, this is different than your .05 kids, right? Or your .05 adults. These people have told you enough that you know that is it. They need all that structure and all that support. The higher the levels of care, and probably the same for mental health, the higher the level of rules and requirements, licensure requirements, credentialing requirements, and so anytime folks are curious, like who can do this or who can do that, at least if it's an enhanced service, it outlines it for you. In an IOP world, it's very specific how much supervision or how much time the supervisor has to be on site, what credential the supervisor has to have, what credential the group leader has to have, or somebody doing individual, but then what credential or status can someone be to do person-centered planning and crisis planning and this and that. Facility licensure is different as well too. For adolescent enhanced services, when we were looking at an intensive outpatient service here in this building didn't meet code because it had to meet a daycare code or school code. And so adults is a bit different, but adolescents, it was a game changer for where we were going to do that. So managed care organizations, I know Smokey is very specific with the practices they accept for substance use. And so when you get into certain services, they'll tell you as long as you're doing all of this and or something in this range, you're fine for billing. Now, that's not put out in the enhanced service definition, but I needed to have some questions answered, and so I consulted with someone in the agency who actually was very involved with the contract piece. And they were able to say, yes, that is outlined and it's specific, and this is what it is. For our adults, we use a matrix model. It is one of the accepted practices by Smokey. We'll get to the website at the end of this, but the SAMHSA website, you can download the entire treatment manual for Matrix. And so you see all the different handouts and sheets and topics that folks are working on when they come to group. I put a 2.5 in there because I am aware we had one out in this area. It's what we call a SACOT, a Substance Abuse Comprehensive Outpatient Treatment Program. That jumps somebody from the 9 hours a week of IOP to 20 hours a week, 5 days a week, 4 hours a day. So that's also a big jump in functioning. If they need 20 versus 9, they're showing enough severity there to get into a program like that. So it's like IOP, but then everything increases, all the support increases. So with level 3, there's varying levels. There's a 3.1, 3.5, 3.7. I put 3.5 and 3.7 on here because these are commonly used levels. There's a fine line. Well, how do you go from a 0.5 to a 0.7? What's the difference there as to why one would go here and one would go there? We're blessed that the ASAM manual gives us a definition for these. Okay, so a 3.5, that is your non-medical community residential treatment. It's 24-hour clinically managed. Not medically, but clinically. So it does not require medical or nursing support. I encourage anybody, if you don't know what is a 3.5 facility in our area, and I don't know what they're called with other MCOs, Smokey has care coordinators, and so we have one for each county. And when I was going through my Cal Locus training, I was blessed to have a trainer. I said, now when I get these numbers, what does this tell me? What kind of levels, of care? And so they gave me a grid, and then I could call my care coordinator and say, I'm looking for a this, and where is this at? And they could tell me here, campus. Internal folks were able to tell me, oh, that's what we have on campus and this and that. So I'm not familiar with all the leveled homes, and I tried to go on the internet just to see, doing different searches to see for certain centers I'm aware of, like Swain Recovery, what ASAM level or level of care, and most of what I'm finding is moderate or intense. It doesn't give me a number. What I do know, at a 3.7, that is 24-hour medical monitoring. Our Black Mountain, ADAC Black Mountain, that's 3.7. I know that because when you do an ADAC referral, if you have 3 point anything else, they will stop it and say it has to be a 0.7. So you need to go back and you need to put the 0.7 in there. So that's the one I am very familiar with that I know is a 3.7, but that does have the medical and the nursing monitoring. It's still not a medical hospital, but it's got the support in place for the medical pieces that are needed. And again, a care coordinator or whatever they're called in your MCO can help you locate those. We get into level 4, that's your medical hospital. That's severe. Somebody is getting round-the-clock medical monitoring and medical care for their addiction disorder. This is where you're going to see somebody with late-stage addiction that may be trying to quit, trying to get sober, or they have been actively participating in their addiction, and the medical overrode that, and now they're in the hospital.
Is it just for late stage, or could it also be just, is this something that might be used for acute?
It could be acute, yes. I mean, it's a hospital setting. It could be acute. I was thinking about someone that was late stage. They could not get on a waiting list for a new liver until they could demonstrate 6 months of sobriety. They had several hospital stints because they were having a lot of difficulties with the liver functioning right. They were also having problems staying sober. So when they drank, it usually spurred another hospital stay. That's how intolerant the liver had become. They did not live long enough to get a new liver because they couldn't hit that 6-month mark. So they were chronic, but yes, acute stage things can put them in the hospital as well too. Good question. If, you've ever had any medical consequences from using, or did you continue? Oh, okay, so that's what that meant? Yeah. Then sometimes they say, well, I wish I would have known what you were asking me, so I could have answered you differently. I know. I can't tell you all that. So, but several months ago, Bill Smith emailed me because he wanted to get a copy of the SUDS booklet we do, because he wanted to take a look at it to try to put it online in Avatar. And so I said, well, I'll make a copy, because I know there's like copyright things, but there's information in there. I'll make a copy of that too. And I said, but how would you do that if it's copywritten? Because we're not allowed to make a copy of that booklet for anybody. Even after it's completed, we cannot make a copy of it. We only make a copy of the back page where we kind of do our summary and have the client sign it. So he said, yes, but a lot of these copywritten materials, you can get a blessing from the company to use that as an online version.
And education.
So I had sent that in, and I said, I would suggest this somewhere in the essay section. And so I just said, this is something that actually the SUDS or the change company gave us for the SUDS, but this is like a very easy read. So some of the folks going through licensure supervision right now, DSM-5 is so overwhelming. Like, somebody handed it to me one time and said, you're going to start assessments. I was like, oh my gosh. They're like, look, there's just only going to be so many things that you're probably ever going to use in here. And I think this does a good job, because now the DSM-5, like DSM-4 just gave you a definition for abuse and a definition for dependence, and then you figured out what drug. Now it breaks it out drug by drug by drug. So here's alcohol and the 5 different kinds of disorders, or here's marijuana, or here's this, and then you're like, man, I didn't know there was all these substances out there. They got a section for everything. So it just puts it all on one page. There is significant mental health history, significant trauma, significant enough that there's been several hospitalizations within the course of 1 year, specifically related to not just suicidal thoughts, but suicidal attempts. 3 in a year. That's glaring. I believe age is 14, so early teens, somewhere around there. Trauma sounds like it was very extensive and throughout a period of time. Outside of the suicidal attempts, there is a reported history of other self-injurious behaviors. And those behaviors, even though they're not out of acts of suicidal ideation, they could be dangerous. If it got out of hand, they could end up in a medical hospital for treatment. That's how injurious they are.
Such as?
Cutting can be one of the self-injurious behaviors, where people cut too much, too deep. They're not, they wind up in a hospital to treat the wound, but they were not trying to commit suicide. They were just trying to cope. Sometimes disassociation can be a coping skill, and it can get dangerous for people if they learned how to dissociate. And so what I do know is there has been reports of using different substances. I'm getting documentation that shows mild use disorder. One of them may be a moderate use disorder. But the documentation is from a hospital, and I don't have the full history there to see how they got mild or moderate. And most of their presenting information in the summary is the mental health stuff. I have a previous assessment that I'm looking at, and I'm missing some information in the substance use section, so I'm unclear about frequency and intensity and date of last use. So I really don't know enough about that, but I believe some of that's going to get updated. And it is accompanied by a substance use assessment that someone's done, the SASE, and so I'm going to be able to use some information off of there as well too. I also know that this youth's environment has been somewhat controlled. because they have been in some high-end, high-level supervision services. And they have been in the hospital now for 5 months, roughly. And so when they walk out, they already know too where they're going. When they walk out, they're going to a high-intensity lockdown facility. And I know under these environments with the levels of control, they've not been using, and not because they can't access their substances. And the history I am aware of is the times that they have used have been when they were not in a controlled environment, were on home visitations, and were able to access it because family members were using. I don't know if they were using with family members, but there's a theme here. When they used, it was in a family home where it was present. And the general information I have is that it has become one, maybe there's others, but one coping mechanism for dealing with the trauma, to kind of numb things out. And so I am trying to figure out now, I already know where they're coming, so I don't have to really do a lot of leveling. I'm still going to have to do a cal locus. But I know that they are going to be coming out in a facility, but I'm concerned about the drug use. And really need to fill in some information, maybe meet with this youth at some point and ask some more questions and kind of see. But based on what I have, I know they've used some of these things more than once. It's gone past experimentation, but I'm not really sure how routine. But I know it's there. So, kind of thinking, you'll notice on the adolescent, when you get to the emotional dimension, they list the subcategories: dangerousness and lethality, interference with addiction recovery efforts. They don't have to have an addiction. You can still answer that question because it would be treatment efforts. Social functioning, ability to self-care, and course of illness. And so you will rate each of those, but remember it's still under one umbrella. So you're still only treating it as one dimension. You just want to kind of look and weight those things out a bit.